Hey everyone! Imagine being a detective, but your primary suspect is completely invisible. And the crime scene? Well, it's the entire human body. Welcome to This Explainer, where we're going to unpack the incredible medical detective story of diagnosing endocrine disorders. When the body's chemical signals misfire, the physical results can be totally profound, and yet the clues left behind are often incredibly subtle.
So here's our game plan for today. We're looking at 4 crucial steps. First, the messaging network. Second, when signals misfire. Third, decoding the clues. And finally, we'll open up the diagnostic toolkit. All right, let's jump straight into section 1, the messaging network, mapping the territory. Okay, so at the very heart of our story is the hormone. Think of hormones as the body's ultimate biological messengers. They're these chemical products created by endocrine organs that act as vital regulatory signals. But what's really cool is they don't just work in one single way. They can act on their very own cells of origin. That's called autocrine signaling, which is basically like leaving a sticky note for yourself. They can also act on nearby, neighboring cells, known as paracrine signaling. That's kind of like yelling over the fence to your next-door neighbor. Or they can travel all the way through the bloodstream to completely distant sites, which is your classic endocrine signaling. And that's like mailing a letter clear across the country.
Now, when we hear the word hormones, most of us instantly picture the traditional heavy-hitting endocrine glands, right? We're talking about the familiar factories. You've got the pituitary glands sitting up in the brain, the thyroid in the neck, the pancreas, the adrenal glands resting right on top of the kidneys, and of course the reproductive organs. These are the classic, dedicated sources of our chemical messengers. But here is a wild twist for you. Our chemical messengers don't just come from those traditional glands. We actually have non-traditional hormone sources that are equally vital. For example, your gastrointestinal tract produces hormones like gastrin and ghrelin, which help regulate your digestion and hunger. And honestly, you might be totally shocked to learn that your adipose, your body fat, is actually an active endocrine organ too. It actively produces leptin to tell your brain when you're full. Even your central nervous system is in on the action, producing various peptide hormones. It's just this massive, fully integrated web of communication.
Which brings us to section 2, when signals misfire, identifying the suspects. So, what exactly happens when this intricate communication network breaks down? Broadly speaking, the endocrine system tends to fail in 2 primary ways. On one hand, we have hormone excess, where the body is just producing far too much of a signal. On the other hand, we have hormone deficiency, where it's producing way too little. And as a medical detective, a doctor has to figure out if the issue is primary, meaning the source gland itself is broken, or secondary, meaning the gland itself is perfectly fine, but the upstream boss signal telling it what to do is the thing malfunctioning.
Let's look a little closer at why someone might have too much hormone in their system. The crucial takeaway here is that excess doesn't just happen out of nowhere. There are specific pathological suspects at play. It could be neoplastic growth. Think of these as rogue benign tumors in the pituitary or parathyroid glands that have defective feedback regulation. They just will not turn off. It could also be autoimmune disorders. Take Graves' disease, for example. That's where a confused immune system actually creates antibodies that actively mimic normal signals and stimulate receptors to overproduce. Or you could be looking at underlying genetic mutations, like the NEN1 and NEN2 syndromes, which actively trigger that overproduction from day one.
But wait, there is a particularly tricky scenario we have to talk about: hormone resistance. This is a condition where hormone levels in the blood are actually very high, but the body's receptors are essentially ignoring the signal. The hormone is there, circulating around, but it's completely invisible to the target organ. This failure of activation is incredibly common today and leads to some severe metabolic dysfunctions, like insulin resistance in type 2 diabetes or leptin resistance in obesity.
Let's flip the perspective now. Section 3, decoding the clues, the patient's perspective. Now that we know how the biology breaks down on a microscopic level, what does the patient actually experience? Being a medical detective here is exceptionally hard because the initial clues are highly vague and diffuse. Seriously, think about it. Unexplained tiredness and fatigue, sudden changes in body weight or shape, altered appetite or excessive thirst, which doctors call polyuria and polydipsia. The problem is, we all experience things like fatigue or weight fluctuation in everyday life, right? It could be stress, it could be aging. Because these signs overlap so heavily with just normal life, spotting the true chemical culprit is a massive challenge.
So how do doctors spot the hidden patterns?
Well, they look for specific combinations. If a patient just has weight gain, honestly, it could be anything. But weight gain paired with profound lethargy, that points specifically toward hypothyroidism or Cushing syndrome. Polyuria and polydipsia point directly to diabetes mellitus or insipidus. Heat intolerance might suggest thyrotoxicosis, and coarsening of facial features is a massive, highly specific clue for something like acromegaly. It really is all about finding the exact combination of these seemingly vague clues to crack the case. Because the physical symptoms can be so ambiguous, a doctor really has to become a meticulous investigator. Taking a highly detailed medical and family history isn't just paperwork, it is the absolute ultimate prerequisite for unearthing the root cause. A doctor needs to know all about previous surgeries, radiation exposure, or pregnancy history, and crucially, the family history. A family background of autoimmune diseases, diabetes, or endocrine tumors can instantly narrow down the suspect list for these invisible chemical misfires. Which leads us to a pretty compelling question, right? Once you have your suspicions lined up based on symptoms and history, how do you definitively catch an invisible chemical culprit in the act? And that brings us to our final step, Section 4, the diagnostic toolkit, interrogating the biology. This is where we move from a clinical hunch to hard, undeniable laboratory proof. To finalize their diagnosis, doctors follow a really strict chronological order of operations. Step 1 is the clinical evaluation, taking that detailed history and physical exam we just discussed. Step 2 is biochemical testing, using lab work to definitively prove that a hormonal abnormality actually exists. And Step 3 is radiologic imaging, like a CT or MRI, to find the physical cause. And I want to stress the absolute golden rule of endocrinology right here. Step 2, biochemical testing to prove the dysfunction exists, must absolutely always precede Step 3, radiologic imaging. You literally never go hunting for a tumor on an MRI without having the chemical proof in your hand first. Now, for that biochemical interrogation, doctors generally rely on two primary techniques. First, they use stimulation tests when they suspect a hormone deficiency. Essentially, they provoke a lazy gland to see if it can produce the hormone when it's forcefully stimulated. Conversely, they use suppression tests when they suspect hormone excess. They actively try to suppress an overactive gland to see if it stubbornly ignores the stop signal, which is exactly what happens in conditions like Cushing syndrome. Let's put these clues together with some real-world lab results so you can see how the diagnostic puzzle pieces finally snap together. Take a patient whose labs show high TSH but low free thyroxine. That definitively points to primary hypothyroidism. The brain is screaming for thyroid hormone, but the thyroid gland is just failing to respond. Now, if a patient has suppressed ACTH but high cortisol, it suggests an adrenal adenoma. The adrenal gland has gone completely rogue and is ignoring the brain's frantic stop signals. And high calcium paired with high PTH, that perfectly illustrates hyperparathyroidism. But here is a huge catch. It isn't just about what you test. Timing matters immensely. Because hormone levels naturally fluctuate drastically throughout the day, the timing of the test is just as important as the test itself. Hormones like T4 have long half-lives, meaning a random blood draw during the day works totally fine, but others require highly specific protocols. For example, testing for excess cortisol often requires a midnight salivary test, simply because that is when your cortisol levels should naturally be at their lowest. You have to catch the culprit at the exact right time. So we've mapped the network, identified the misfires, decoded the patient's clues, and interrogated the biology to prove our case. But looking at this whole incredible system leaves us with one really wild thought to ponder. If our bodies are constantly communicating through these complex, invisible signals every second of the day, what other hidden biological conversations are just waiting to be decoded? The frontiers of neuroendocrinology are absolutely vast, and the next great medical detective story is already unfolding inside you right now. Thanks so much for joining me for this explainer, and keep questioning the incredible biology happening just beneath the surface.